Okay, this is the chest radiograph frontal projection provided to me. I can appreciate that there is the left hemithorax shows an opacity, veil-like opacity, and in the upper left upper zone, and there's also tenting of the diaphragm, and there is lucency adjacent to the aortic knuckle, and there is also deviation of the trachea towards the left side, and considering these features, there is most likely the left upper lobe collapse in this region. However, the mid and lower zones, they appear unremarkable, and the right hemithorax, it appears to be unremarkable to me. And the region of the tracheal bifurcation at the level of left main bronchus, that is not clearly visualized because of the collapse. The costophrenic angles bilaterally and cardiophrenic angles appear to be unremarkable to me. Heart lies within the normal range. And regarding the supraclavicular region, the lateral chest wall, and the region of the clavicles and ribs, they appear unremarkable to me. And regarding the hilar, I can appreciate the right hilar region is normal, but the left has some opacity within it. Maybe might be because of the pathology lying over here, and the apices also, the remaining area appears unremarkable. I cannot appreciate any pathology beneath the domes of the diaphragm. So I would like to, I would like to have the history of the patient, whether the patient has got any history of breathlessness or fever. Either it is because of a consolidation, or secondarily, if no fever, it could be a mass. So I would like to review it with the help of a CT chest with contrast in order to confirm my findings.
So before we go to CT scans, what are potential causes of, do you hear me?
Yeah, I can hear you.
So this is like a classic example of lobar collapse, okay?
Yeah.
And lobar collapses, I think this like basic radiology. For me, if I'm an examiner, if you do even the best in all cases and you fail in the FRCR, like for example, if you fail to recognize lobar or basic collapses, this is like a major problem with you. So excellent. This is an example of left upper lobe collapse, which is the Luftsichel sign. Do you know why do you see the lucency around the aorta?
Because of its veil-like opacity, giving it a typical Luftsichel appearance. So that is.
Do you know why do you see the Luftsichel appearance or the Luftsichel appearance? Do you know why?
That is no, sir. You can tell me. Yeah.
No, because usually the suprasegment of the left lower lobe will migrate and will insinuate the aorta. Yes. So the aorta doesn't touch the collapsed lung, so it's not silhouetted. So that's why.
Okay.
And this is the lateral view. So any added information in the lateral view?
Yeah, I can see on the lateral view that there is an opacity in anteriorly present in the retrosternal region. That is the area of collapse, which is confirmed on this lateral view.
So the collapsed upper lobe, where does it move? Anteriorly, posterior, where does it move?
Anteriorly. Anteromedially.
So to complete your description, now here you have to tell me what are the causes of lobar collapses.
Okay, so it is secondary.
Like in this situation.
Yeah.
What are your main concerns?
As it is a skeletally mature patient, so I would like to know the age. So it could
Maybe
be
50.
secondary to. Okay, it could be secondary to a mass which is present in the region of the bronchus, and which is obstructing it and leading to this lobar collapse. And if it's a young age patient or a child, it could be because of mucus plugging. So there are many reasons. The basic two reasons are here. And then even if there is a whole opaque hemithorax, it could be secondary to previous pneumonectomy or things like that. So in my view, these are the two ways.
Okay, great. Now, to make your description particularly you are doing now for the exam, it's always important to be proactive. Like, I mean, you mentioned that there is perfect, there is left upper lobe collapse. This could be related to a central mass, whatever. Now you have to take this further, and you have to tell the examiner that this is like a suspected cancer, whatever, or suspected finding. I have to call the physician and tell him, because unfortunately, many times we see a finding, it is like ignored by the radiologist, the physician, and the patient may come with advanced disease that is beyond treatment, curative treatment.
Yeah.
So here I would say that, okay, I would do a CT scan, okay, which is totally perfect, and I will add that I will also contact the referring physician to inform him about this important finding, okay? Because the patient may go and not come back, and so you save the life of the patient. And CT scan is clearly, I mean, there's like just show that the central mass, this tend to be bronchogenic carcinoma, and there's obstructive mass and underlying associated lobar collapse. Okay?
Yes, sir. Thank you.
Good. So remember, I mean, this is the prototype of lobar collapses. I mean, you have to, understand, memorize lobar collapses very well. The most difficult of them will be the left upper lobe collapse. The second most difficult will be the right middle lobe collapse. Okay.
Yeah.
So this is a companion case. This case was a pneumonia, and definitely you know it's pneumonia because there is no shift in the mediastinum, there is no uplifting of the hilum, and there is no luftcesial sound. Here, I mean, you see that because the consolidation is reaching the surface of the aorta, you don't see the lucency around the aorta. Okay, so this is the way to distinguish between left upper lobe pneumonia or consolidation and left upper lobe collapse. Okay?
Yes, sir.
I'm presented with X-ray chest frontal projection of a skeletal mature patient who presented with bloody sputum. There is evidence of the left hilar enlargement. However, the right hilar appears unremarkable. I don't see any evidence of any pulmonary nodule proliferation in both lung fields. Cardiac size is normal, and the bony skeleton reveals no abnormality. And,
maybe the X-ray not clear to you, but there is some nodular haziness here.
Yes, there are some non-homogeneous small faint opacities in the right pericardiac region, in the middle lobe medial segment, and also in the left lung mid-zone. And keeping in view history, my differentials would be, it would be an infective process like tuberculosis.
Wait.
Could be even...
Before you, I mean, just complete your description and then move to the discussion. It's very important again in the exam to give a good description, because number one, good description will give you more marks because there are marks on description. The second thing is that when you describe things, this will give you more time to think about possible differential diagnosis. Okay?
Okay. However, the rest of the soft tissues appear unremarkable. No evidence of any lytic or sclerotic lesion in the bony skeleton. This visualized part of the upper abdomen reveals no abnormality. So keeping in view the left hilar enlargement and the faint opacity, soft tissue faint opacities in the right lung, right lung pericardiac region and left lung mid-zone, my differentials would be either it could be an infective process like tuberculosis. Even my second differential would be some neoplastic lesion, central obstructing mass with some deposits in the lung. And next, I would like to go for a contrast-enhanced CT chest, and I would inform the findings to the referring physician, and we'll discuss the further management
So what kind of CT scan do you want, like with contrast or without contrast?
I would go for contrast-enhanced CT.
Unfortunately, we have this CT without contrast, but anyhow, it will serve.
Okay, I'm presented with the axial lung windows of the both lungs. There is an evidence of speculated soft tissue opacity in the right lung, middle lobe, lateral segment. There's also evidence of a similar looking opacities in the left lung, in the superior segment of the left lower lobe, as well as in the anterior segment of the left upper lobe. And I would like to see the mediastinal window to confirm the left hilar and to confirm and further evaluate the left hilar enlargement.
It was a prominent, there was lymph node enlargement there.
Pardon, please?
There was a lymph node enlargement.
So since there was lymph node enlargement, I would still stick to the differentials. It could be a central obstructing mass.
Before you go to the differential, now, what is specific about these nodes?
The irregular margins, they are more suspicious for a neoplastic lesion. So next I would go for contrast.
Before you go to presumptions, so these nodes are irregular in margin, speculated in margin. What about that location of is there any specific distribution of these nodes?
They are randomly distributed, one on the right side and the two on the left.
So this is adjacent to the vessel. Here they are adjacent to the vessel. Here maybe adjacent to the vessel. So what do you call this distribution? Peribronchovascular.
Peribronchovascular distribution.
Peribronchovascular distribution. This description will be very helpful to you when you generate your differential diagnosis. Okay? So let's sum up the findings for me, please.
So the cumulative findings, there is evidence of left hilar enlargement and few variable sized nodules in the left and right lung field with the locations, as I mentioned before, some showing irregular and speculated margins in the peribronchovascular distribution. So I would like to rearrange my differentials, which I told on the plain X-ray. It could be a central obstructing mass with some metastatic deposits. It could be even sarcoidosis. And the third, it could be an infective process like tuberculosis, but it would be the least likely differential here. Next, I would like to see the contrast enhanced CT.
Remember the clinical scenario. This patient had HIV with bloody sputum. HIV with bloody sputum, okay? So all what you said is correct, but it's almost always good to, when you establish your differential diagnosis, remember to keep in mind the clinical scenario, okay?
Even in the tuberculosis is more common in the AIDS patient.
No, yeah, but it is the classical appearance of tuberculosis?
No.
Okay,
it looks more like neoplastic.
What kind of neoplasm that can develop in HIV positive patients? If you think of neoplasm, what kind of neoplasm that develop in HIV patients?
In HIV patients, they usually present with Kaposi sarcoma.
Kaposi, excellent.
Yes, but that's
not
any
the
other
case tumors?
Here. Sorry, I don't remember the rest.
Lymphoma.
Lymphoma, yes.
Okay. Now, so we are now generating good differential. Any other possibilities other than neoplasm? You mentioned infection. Okay. But infection, but TB is not a good choice here.
Yes.
Because in HIV positive patient, this immunocompromised patient, you see either TB in the form of miliary TB or in the forms of post-primary. I mean, very unlikely the patient as a cavitary TB. You will not see TB like this.
Yes,
okay?
And since these nodules are not surrounded by the ground glass haze, so I wouldn't keep the fungal infection invasive.
But still, fungal infection is a possibility even without the grounded glass. Okay. Yeah. So fungal pneumonia should be on top of your differential diagnosis in addition to Kaposi sarcoma. Definitely in different clinical scenarios, there are other differential diagnoses. Okay. I will show you in the next slide, but I mean, you have to structure your differential diagnosis based on the findings. So what's your next step here? Now you mentioned 2 or 3 good differential diagnoses. That's fine. What's your next step here?
I would go for contrast enhanced CT.
Okay. What else?
Next, I would correlate my findings with labs. If the patient, I would like to see if the patient is, how much is the CD4 count. And depending on that, I would like to rearrange my differentials and
Okay. Now the patient had a bronchoscopy. The patient had a bronchoscopy and they found a lot of hemorrhagic spots in the bronchi. Now,
then I would like to go for the bronchoscopic biopsy at the same time.
Yeah, but before, I mean, if you see this hemorrhagic foci within the bronchi, then, I mean, out of these differential diagnoses, what is the most likely diagnosis?
I think it's fungal infection is the most appropriate one.
Kaposi sarcoma, because Kaposi sarcoma is a vascular tumor. So when they do bronchoscopy, they will see a lot of hemorrhagic foci within the bronchial system. Okay. So this was a case of Kaposi sarcoma. So if you are facing bronchovascular parenchymal opacities in HIV positive patients, the main differential diagnosis should include Kaposi sarcoma and lymphoma in addition to fungal pneumonia. Now, other differential diagnoses in different scenarios include organizing pneumonia, sarcoidosis. You mentioned sarcoidosis, and usually it gives you the so-called galaxy sign, sarcoid galaxy sign, in addition to like Wagner grammatosis, or we call it now GPA. So there's a differential diagnosis, long list. However, structure for that, you have always to base your differential diagnosis on the clinical scenario, okay? Not on the Chapman scenario, we have a long list, no. Tailor your differential diagnosis based on the best differential list that fits the patient history, okay?
Sure.
Thank you very much.
I'm provided with chest X-ray, frontal projection of a skeletally mature 50-year-old patient, and in which I can see in the left hemithorax, there are peripherally based patches of consolidation are noted, and there are few A-space specification also noted in the left lower zone. And in the right hemithorax, there is again a peripheral patch of consolidation noted in the right upper zone, and along the right middle and lower zone, there is again A-space of specification is noted with suspicion of a thick wall cavity with an air fluid level. Bilateral CP angles appears to be unremarkable. The rest of the visualized bones and the soft tissues, they appears to be unremarkable. The bilateral breast shadows are unremarkable. So my likely diagnosis would be some infective etiology. And
like what?
Sir, so some infection in which there is also cavity formation, like Staph aureus maybe, or
nowadays. So where are you now? I mean, in your practice now, if you see this appearance, okay, yes, what was the first thing that comes to your mind? What kind of infection that should come to your mind immediately?
So, bronchopneumonia, some sort of bronchopneumonia.
Like what? COVID-19. Would you consider COVID?
Sir, I considered COVID-19, but there, in addition to peripheral patches, there are central. So I would keeping it
nowadays. Every pneumonia consolidation like this is COVID-19 until proven otherwise. So be careful.
So, but isn't it? It's indeterminate for COVID-19 as there are central patches as well.
Yeah, but these central patches may be peripheral on the CT scan, and then again, I mean, for X-rays is not very specific. So, okay, so and still you need to rule out COVID-19 even when you have this appearance. Okay.
Okay, sir. Okay.
So pneumonia is your first differential. Okay, so what are you going to do?
Sir, I'm going to correlate it with the history of the patient. He's having a fever and shortness of breath, and next I can. So in our practice, we will advise follow-up and after antibiotic cover. And if these are not resolving, then we go for some other investigation like HRCT.
Okay, so the patient was treated. There is no response to treatment, so we have to escalate the differential diagnosis, right?
Sir, in CT scan again, the axial images are provided. and in the lung window, and I can see there are patches of consolidation which are predominantly peripheral based, and they are not following any lobar pattern, and with the few air bronchograms are also noted in these consolidations. So in a peribronchovascular pattern. So, sir, my differentials would be, and he is not responding to antibiotics as well. So I will keep bronchoalveolar carcinoma in my differential. And
a good choice. Anything else?
So poop, cryptogenic organizing pneumonia,
Excellent.
and chronic eosinophilic pneumonia.
Tamam, that's fine. So we have 3 differential diagnoses now. So which are all valid differential diagnoses. Now, if I tell you that this patient is asthmatic, then what is your preferred differential diagnosis?
Sir, so in asthmatic allergic bronchopulmonary aspergillosis or
Well, this is not the pattern of ABPF, allergic bronchitis. I mean, again,
yes,
out of the differential diagnosis that you mentioned cancer, which is a good differential, which is bronchoalveolar carcinoma, the former bronchoalveolar carcinoma. They changed the name now.
Chronic eosinophilic pneumonia.
Chronic eosinophilic pneumonia. So how to confirm the diagnosis?
So we can look for raised eosinophilic count in the blood CP.
And you may need to do a biopsy as well.
Yes, a biopsy can also be done.
Excellent. So this is the differential diagnosis of when you have bilateral peripheral pulmonary opacities. You may consider pneumonia, including chronic eosinophilic pneumonia or cryptogenic organizing pneumonia, and you can see here, you see the way we call it perilobular opacity consolidation. So this is secondary pulmonary lobule. You see some consolidation around it. Again, this is a feature of organizing pneumonia, COP. Okay.
Yes.
But I mean, again, with the history of asthma, then this tend to be eosinophilic pneumonia. Vasculitis, like Church-Strauss vasculitis, and the differential diagnosis between cryptogenic CEP, chronic eosinophilic pneumonia, and Church-Strauss, you need to do biopsy to see if there is vascular involvement or not. Tumors, including bronchoalveolar carcinoma or lymphoma, and pulmonary infarction, but usually pulmonary infarction is a bit different. But still, you have to consider it when you have peripheral consolidation, but usually not bilateral like this.
Yes.
Okay. Now, in this case, you have 2 images. Okay. One of them is sarcoidosis, and one of them is miliary tuberculosis. So you have to tell me which one is TB and which one is sarcoidosis.
Sir, the first one on the left side is sarcoidosis, as I can appreciate a nodular thickening of along the peribronchovascular and lymphatic and pleural base. And the second image on the right side is miliary pattern, suggestive of miliary TB, as it is more so on the centrilobular with there is sparing of the peripheral rim, subpleural rim.
So you said there's a sparing here in the right lung, in the right exam? Sparing of the, what? Say it again, please. Sparing of what?
Sparing
I didn't
of
hear.
pleural.
Sparing of what? Pleural surfaces?
Yes, sir.
But there are nodules here attached to the pleural surface. So how come you are saying it's sparing of the surface? Hello? So there is no sparing. There is involvement of the pleural surface. Okay?
Okay, sir.
So let's move to the first case. You mentioned So you did well. The left case is sarcoidosis and the right side is miliary tuberculosis. Okay? So now let's move, check the first case here. So the findings here that indicate sarcoidosis is that nodularity of the vessels, nodularity of the pleural surfaces, and this kind of cluster of micronodules that are reaching the surface of the lung, okay? But however, these nodules are following the, what do you call this kind of spread? What do you call this kind of micronodular distribution? It's called the perilymphatic distribution. The perilymphatic of distribution of pulmonary micronodules, okay?
Yes, sir.
Is it pathognomonic for sarcoidosis or there is a differential diagnosis?
So there is a differential of lymphangitis, carcinomatosa, in which there is nodular spread, but that is more so in the basal or dependent area. In sarcoidosis, upper and middle lungs zones are more involved.
But any other differential diagnosis? Pneumoconiosis, okay? Like silicosis, bagasosis, berylliosis, etc. Except it's for the asbestosis because the asbestosis affect the lower lung cells. Okay? On the right hand case here you have the, what do you call this distribution of the micronodules?
It's more so the centrilobular pattern.
No, it's not the centrilobular. The centrilobular pattern should not involve the surface of the pleura, okay? In the micronodular pattern distribution, we have three types of distribution. The random distribution, the perilymphatic distribution, and the centrilobular distribution. Okay? In the centrilobular distribution, the first thing is to check the surface of the pleura. If the surface of the pleura is involved, then this is not centrilobular because centrilobular, the center of the lobule should not be in the surface of the pleura. It should be in the center of the lobule. So here you see involvement of the surface of the pleura. So, true, correct?
Yes, sir.
So this indicates that this is not centrilobular distribution. Then the next step, it is either random or perilymphatic. Okay? So are the nodes only exclusively here involving the perilymphatic route? No. So you are ending up with one distribution, which is a random distribution. Okay? The random distribution, the differential diagnosis for the random distribution of the lung nodes include, as you mentioned, miliary tuberculosis. Anything else?
Miliary metastases.
Miliary metastasis from where?
From thyroid and renal cell.
Thyroid and renal cell carcinoma, correct. Anything else?
And pneumoconiosis can also be in the differential.
But not the random pattern. The random pattern, it is hematogenous spread. Okay? So the other type is the hematogenous spread of fungal infection like histoplasmosis. Okay?
Yes, sir. Fungal.
So micronodular lung disease, we have three types of distribution, but I mentioned only the two, the perilymphatic distribution. Like in this case, there's sarcoidosis, as in the diagnosis here. Pneumoconiosis, except for asbestosis and lymphangitic spread. For the random distribution, it's basically miliary tuberculosis because this is hematogenous spread of disease. Fungal infections such as disseminated histoplasmosis and metastasis from hypervascular tumors like renal cell carcinoma, choriocarcinoma, thyroid medullary carcinoma, etc. Okay? So this is a prototype of how do you approach pulmonary micronodular disease. So we're presented with this X-ray.
I'm provided with a chest X-ray frontal projection of a mature skeleton, in which I can appreciate that there appears to be tubular opacities are noted in the right upper zone, and giving a finger and gloved pattern. Now I'm looking at the left upper zone, which appears to be unremarkable, and
you may see some ring lucencies here. Some
yes,
ring lucencies.
There is lucis on the left upper zone as well. The hilum appears to be unremarkable, and the heart shadow is also normal. And now looking at the domes of the diaphragm, they appear to be normal, and CP angles are acute.
Maybe some linear atelectasis, which is not important.
Yes, and noted in the right lower zone. CP angles are acute. The visualized ribs also appear to be unremarkable. Now, looking at the trachea and the mediastinum, I cannot appreciate any abnormality. The visualized soft tissue also appears to be normal. So, based on this finding, likely my diagnosis is of ABPA, allergic bronchopulmonary aspergillosis, and
any other differentials?
It is not that I can. It's typical of if it would have been in the upper and middle lobes with the distant bronchiectasis, I would have thought of cystic bronchiectasis. Sorry, cystic fibrosis, and
cystic fibrosis is a good differential, of course.
And it can also be bronchial atresia.
Excellent. So what are we going to do next?
I would like to go with the HRCT correlation.
Okay.
And
this is with contrast.
And in this, I can appreciate I'm provided with the axial sections of CT chest with contrast, lung, and the mediastinal window, in which I can appreciate that there are dilated bronchial channels with fluid that appear to be filled with fluid, and giving a typical of finger in the gloved pattern in the involving the right upper lobe, and on the mediastinal window I can appreciate that there appear to be a few lymph nodes are noted in the right paratracheal region, and however the vascular pedicle appears to be unremarkable, and the trachea is also normal, and the visualized bones and soft tissue are also unremarkable.
So the disease involves both the right upper lobe and to a lesser extent the left upper lobe, okay?
Yes.
Okay. So what is this?
These are likely mucus-filled bronchi and mucoceles, and allergic. It confirms my diagnosis of allergic bronchopulmonary aspergillosis.
So what makes you confident it is ABPA? Give me two things.
First, that there are no other, the adjacent lung parenchyma appears to be normal. I cannot appreciate any dilated, or I cannot appreciate any other bronchiectasis. It is secondly the location. It is involving the upper zones and the upper lobes of the lung, and.
What about the density of the, I mean, again, sorry, we don't have the pre-contrast, but what do you think of the density of the mucus plug?
The density appears to be more than that of fluid. This is likely because it is filled with mucus. It has a proteinaceous component, so the density would be slightly higher than that we see in the fluid component.
Do you have any other explanation why you see hyperdense mucus plugging in allergic bronchopulmonary aspergillosis? It's basically the presence of the fungal hyphae.
The fungal hyphae, yes.
And this is not only in the thorax. Like if you have fungal sinusitis,
yes,
you will see that there is hyperdense mucus within the sinuses. And
yes.
Okay, So this is
manganese. That is why it is hyperdense.
No. What is the clinical picture of these patients when they come? I mean, they have to ask me about one single condition that coexists with allergic bronchopulmonary aspergillosis. Do you know what it is?
No, I can't think.
Asthma.
Asthma, yes.
So in general, asthma, if the patient, any asthmatic patient, asthma should usually doesn't cause any major problem on X-rays, maybe hyperinflation. Okay, but if the patient is asthmatic and you see bronchiectasis, it is ABPA until proven otherwise.
Yes.
So, okay. So can you tell me why is this patient not having cystic fibrosis?
It's because there's in cystic fibrosis,
it's the same distribution.
It is, yes, it's the same distribution. It's in the upper and middle zones, and in it they're not usually mucus filled. They're more like
can be. They die because usually of mucus plugging and recurrent pulmonary infection.
The cystic fibrosis.
The answer is E, the chest wall. Look at the chest wall. Do you think it fits a cystic fibrosis patient? Honestly, all the cases of cystic fibrosis that I've seen, all very emancipated, thin persons. Yes. They don't have, subcutaneous fat. But this patient, mashallah, he is full. Okay, so this cannot be cystic fibrosis. It's just a soft sign.
Yes.
Okay, so you are correct. ABPA, finger and glove sign, and this is a case of cystic fibrosis patient. And cystic fibrosis patient, similarly, you see bronchiectasis. You see this patient is extremely thin. Okay, and there is another soft sign, which is that the fatty replacement of the pancreas. Okay.
Yes, sir.
Definitely, there's other differential diagnosis for bronchiectasis, including like congenital conditions, recurrent infections. But these are the main things you have to keep in mind. If the asthmatic patient with bronchiectasis, it is ABPA until proven otherwise. Okay.
Yes, sir.